fine. So without further ado, I'd like to introduce Dr. Katie Kaligi, who'll be presenting today. Dr. Kaligi is a professor in the Department of Family Medicine and the Division of Geriatric Medicine and Gerontology. She is a seasoned clinician with experience in both outpatient and skilled nursing level care. She has a special interest in geriatric oncology and is working to develop a special clinic here at UCI Health in that regard. And Dr. Kaligi today will be talking on weight loss. Thank you, Dr. Kaligi, for joining us.
Thank you. Good afternoon, everybody. So we're going to talk about weight loss and patient with cognitive impairment. And next slide, please. So our objectives are to understand the mechanism of weight loss in older adults and those with dementia, review the risk factors for weight loss, discuss the workup of weight loss, and understand the management strategies for weight loss in older adults. Next slide, please. What is the involuntary weight loss? Is the weight loss of 10 pounds or 4.5 kilogram or more than 5% of usual body weight over 6 to 12 months. Next slide, please. Prevalence of involuntary weight loss in elderly. The prevalence is about 13% of older outpatient, 25 or 50% happening of hospitalized older adults, and more than 50% of nursing home residents are experiencing weight loss. Next, please. Causes of involuntary weight loss. Is about 50% of all weight loss are related to organ problems, organ failures, including heart failure, COPD, renal failure, or also chronic infection, inflammation, and GI conditions, medication side effects, or neurodegenerative conditions like Alzheimer's disease or Parkinson's disease. 20% is neoplastic, 20% are idiopathic, including age-associated sarcopenia, and 10% is psychosocial. Next, please. Also, we can use this mnemonic of Meals on Wheels, which can be, M is for medication effects, E goes for emotional problems, A for anorexia nervosa or alcoholism, L life paranoia, S is standing for swallowing disorder, O stands for oral factors like poor fitting dentures or cavities, N is, stands for no money or nosocomial infections, W for wandering or other dementia-related behaviors, H standing for hyperthyroidism, hypercalcemia, hypoadrenalism, E stands for enteric problems, F stands for, another E stands for eating problems, inability to feed oneself, L for low salt diet and low cholesterol diet, and S stands for shopping and stones. I really don't know why stones come here, but it was in the literatures. So next, please. So prognosis. So weight loss actually is not a good thing happens for patients. I always tell my elderly patient that we should keep their weight for the BMI between 27 to 29. So a lot of elderly wants to have a weight loss, and I always tell them about the mortality rate that is related to weight loss in elderly. So 10% of weight loss usually represent protein, energy, malnutrition. 20% loss associated with impaired immunity system. And excess loss of lean body mass is associated with poor wound healing, infections, pressure ulcers, depression, and mortality, increase the mortality and also affect their functionality. As I told earlier, mortality rates are lowest for individuals with BMIs of between 27 and 29. Next, please. So this algorithm also shows that survival probability is less with the patient for weight loss in compared to patients with stable weights. Next, please. Unexplained weight loss in ambulatory elderly, published in JACS in May 1991, was a case series chart review study which revealed that 24% of 45 cases had no definite etiology of the weight loss after 2 years of extensive clinical investigations. And depression was found to be the most common diagnosis was about 18%, followed by cancer, which was about 16% of diagnosis. Next, please. Causes of weight loss in a community nursing home. That was, again, another study in JACS, June 1994. Retrospective chart review of all weights over the previous 6 months and in-depth examination of all residents who lost 5 or more pounds over the period. The study has demonstrated that a careful history and physical examination leading to appropriate lab testing can identify the cause of weight loss in the majority of subjects. So that means the exam and blood, appropriate lab can help us to find the majority of weight loss. And a number of the identified causes are potentially treatable. However, it should be noted the majority of residents with weight loss and depression were already receiving treatment and that their depression was proving highly resistant to conventional therapy. Next slide, please. Factors associated with weight loss, low BMI, and malnutrition among nursing home patients. Again, another study in JAMDA 2013. It shows that the factors most constantly associated with weight loss, low BMI, and poor nutrition is mostly poor oral intake, swallowing or chewing difficulty, and older age. So that's actually our factors are most of them. And also depression was effective for weight loss in elderly, as well as immobility and dysphagia and female gender for low BMI. Next slide, please. So medication may cause weight loss. So some medication can cause anorexia, basically just affect the appetite. And the medication, the example of this medication is digoxin, phenytoin, SSRIs like fluoxetine, calcium channel blockers, H2 receptor antagonists, proton pump inhibitors, narcotics, NSAIDs, furosemide, potassium supplement, ipratropyl bromide, and theophylline. Next slide, please. Also, medication can interfere with taste or smell, like angiotensin receptor ARBs and allopurinol or anticholinergics, and or reduce availability of specific nutrients like PPIs that can reduce the vitamin B12 or decrease the calcium absorption. Inattention or drowsiness can, like muscle relaxant, benzodiazepines, then can affect also weight loss because the patient spend more time in the bed rather than waking up and eating appropriately. Dysphagia, like bisphosphonate, doxycycline, as we know, can affect the esophagus and can cause a problem with swallowing. Any change, altered change of taste or dry mouth, xerostomia, or constipation. So these all can affect the appetite and cause weight loss. So, next, please. And weight loss, there is a study, it was a study in August 2015, was about weight loss associated with cholinesterase inhibitors in individuals with dementia in the national healthcare system. It was a retrospective cohort study from 2007 to 2010, comparing weight loss in individuals with dementia, newly prescribed cholinesterase inhibitors, and those newly prescribed other chronic medications. At 12 months, 29.3% of participants taking cholinesterase inhibitors had experienced weight loss compared with 22.8% of non-users. So that was significantly data that anticholinergics, cholinesterase inhibitors can affect weight loss in dementia patients. Next, please. So diagnostic tests, based off the physical exam and history, we can also order some diagnostic tests, including like a CBC, basic metabolic panel, checking the liver function, thyroid test, of course, C-reactive protein to see if there is an infection or inflammation, as well as ESR. We can also check the glucose. I have some cases of having diabetes in older age. LDH measurements, protein electrophoresis, ferritin, to check there for anemia or other reasons, and also urine analysis and fecal occult blood to see if there is any blood in the stool. Also there are some simple imaging like a chest X-ray or abdominal ultrasound can be used as just simple workup for weight loss. Next, please. So for malnutrition test, we can check the serum albumin or pre-albumin. Serum albumin usually doesn't have a specificity and sensitivity, enough sensitivity for that malnutrition, but serum pre-albumin, because having shorter half-life, it's about 48 hours, is better helping us for a reflection of the changes even after nutritional interventions and recovery. So we can check the patient's pre-albumin prior to treatment or after assessment and treatment, and it helps us to basically follow up for the malnutrition. And pre-albumin actually is not really reliable marker when the patient has inflammatory conditions. Next, please. So dysphagia is one of the common problem in dementia patient, which can cause malnutrition, dehydration, weight loss, functional decline, fear of eating and drinking, and decrease in quality of life. So we're gonna focus on dysphagia right now. Next, please. Prevalence of dysphagia. So we see about 13 to 57% of all kinds of dementia experiencing dysphagia. Dysphagia can develop during the latest stage of frontotemporal dementia, but we can see dysphagia even at an earlier stage of Alzheimer's dementia. Next, please. Etiology. The high prevalence of dysphagia in individuals with dementia likely is the result of age-related changes in sensory and motor function, in addition of those produced by neuropathology. Next, please. So this picture is, I like this picture because it's very simple and shows that all factors that can cause a dysphagia in patients with dementia. So we see the olfaction and taste sensation is decreasing. Dental status, most people, they have poor dentition or dentures, cavities, stuff like that. So muscle function or muscle weakness can affect play a role is from the tongue and mouth, oral muscles, and also the larynx and pharyngeal muscles. Salivary gland, the secretions, dry mouth is a major problem in elderly. Skeletal changes, having the osteoarthritis of the neck and difficulty movement and positioning. These are all factors that affect, can cause dysphagia in elderly patients, especially with dementia. Next, please. So for swallowing evaluation, that's the most common thing we do. We refer the patient for modified barium swallow. If the patient is in nursing home setting or hospital, they can do bedside swallow assessment, which is done by a speech therapist. And there are some questionnaire, a single question, what about swallowing? Or there are some sitting swallow questionnaire or other kind of questionnaire that we can ask the patient for dysphagia evaluation. But the one that we mostly use in clinic for outpatient setting, we refer the patient for modified barium swallow, which is done by radiologists as well as a speech therapist. And we get all the recommendation by a speech therapist. Next, please. So what is the management strategies for weight loss? Next. So non-pharmacological management. So we really focus on non-pharmacological management as the first line. So what we can do, we can cater to food preferences with appealing foods, provide hand and mouth care as needed, provide feeding assistance, avoid excessive salt and sugar, give adequate time for meal, address cultural expectations. So each culture, especially elderly, they wanted to have their own cultural meal, like a Korean, they want to have Korean meals, Iranian, Persian meals, or vice versa. So next one. We should avoid any therapeutic diet. A lot of time in their older Alzheimer's dementia patient, we don't want to focus on the strict diet for diabetes or low cholesterol diet anymore. So we wanted to give them anything that they like to eat. Situate comfortably for eating, place people together for meals to increase sociability. Definitely it's good to go to dining room with the other residents in nursing home or assisted facilities.
Let's let him go. I'm going to do.
Attends to consistency, color, texture, and temperature of food. Use herbs and spices to compensate for reduced sense of taste and smells, which is very important, especially patients with low salt diet, that we should go with more spices. And avoid giving the patient hard to open packages. Next, please. Non-pharmacological management, also including this modified diet, like a pureed or mechanical chop diet. We can use pureed diet for the patient with a weakness, and also for dentation, as well as having also dry mouth. Same thing with mechanical chop diet, as well as also, as mentioned earlier, with modified barium swallow, speech therapist give us all these recommendations, which kind of consistency is required for the patient. Also, we can send the patient for a speech therapy or swallow rehab. They can work on the muscle, chewing muscles, and helping them also teach them how to position, to eating upright. And chin tuck maneuver, if we can use it for patient with a stroke, that it helps to basically change the diameter of pharynx and help the bolus to go through the pharynx and esophagus with delaying the glottic disclosure and reduced aspiration. Head turn maneuver helps for the patient with a stroke. So to turn the head toward the weak part. So then they get the gravity, it helps to the bolus to go toward the strong side. So actually they push the gravity toward the strong side. Next one. Pharmacological management, we really need to avoid using any prescription as much as possible, because there is no adequate evidence for improvement of long-term survival and quality of life. And using a non-pharmacological management instead is very recommended. And all medication that we're using actually are off-label. Next, please. So we can use mirtazapine. And mirtazapine is very is our favorite, I think, in giving the prescribing to geriatric population, especially when there is a component of depression and insomnia. But we have to be careful of other side effects of, especially when we use it with other SSRIs, when we can increase the risk of serotonin syndrome or, the other side effect of mirtazapine. Yeah. But overall, is a medication that we don't want to prescribe for everybody, but is very helpful when it's a component of depression and insomnia. Cyproheptadine, we don't use it at US anymore. I really don't know anybody using it, but it's a strong AGS Pierce criteria warning against using it because of causing confusion. Dronabinol, which is a cannabinoid, we can use for basically, especially with patients with cancer or HIV patient, to boost the appetite. Usually the dosage is 2.5 milligrams twice daily, used before lunch and dinner. And again, it can cause, drowsiness and dysphoria. So I usually don't, recommend for a patient with dementia as a routine medication as well. Megestrol, which is progestin that stimulates appetite, again is a strong AGS beer criteria warning against its use, and weight gain is primarily fat and is not improving the quality of life or survival, and the big risk of DVT, fluid retention, edema, heart failure exacerbation, and death. I never used Megestrol for any patient with dementia and dysphagia or weight loss. Enteral feeding, so we can use NG tube, or we can use also G tube feeding. NG tube feeding is just for first week of a stroke to allow to administer the nutrition and medication. We don't recommend long-term use of NG tube for all the complications and risks. The other one is a percutaneous endoscopic gastronomy or G tube feeding that we also use longer term if dysphagia persists after the first week of a stroke. Best for patients with some degree of rehabilitation potential and actually, again, doesn't improve mortality or reduce aspiration risk. Next slide. So AGS feeding tubes in advanced dementia position statement is very interesting. I wanted to share with you. Feeding tubes are not recommended for older adults with advanced dementia. Careful hand feeding is at least as good as tube feeding for the outcome of death, aspiration, pneumonia, functional status, and comfort. Next one. In observation studies, tube feeding has not been shown to prevent aspiration, healing pressure ulcers, improving nutritional status, or decrease mortality in persons with advanced dementia. Tube feeding is also associated with substantial burden, including recurring or new onset aspiration, tube-associated and aspiration-related infection, oral secretions that are difficult to manage, discomfort, tube malfunction, use of physical and chemical restraints, which is not good at all for the patient with dementia, can increase the risk of delirium, and also pressure ulcer risk increasing with tube feeding. Next. Additional recommendation, environments with less noise and clutter are more conducive to eating than chaotic ones. In nursing homes, nurse training and staff education improves feeding strategies in residents and dementia. Diets should be liberalized based on residents' preference. As we talked earlier, we should not have a strict diet for the patient with dementia. And adequate fluids should be given with feeding to enhance the taste. Additional recommendation, although a true evaluation of reversible causes of these problems should be conducted, persistent eating difficulties may be the consequence of progression of neurodegenerative process. So I always tell the patient family and basically patient's family, although we use all these things, but when the Alzheimer's is progressing and patient stop eating, we have to let the nature to do the, what they wanted to do. So basically, when the patient doesn't want to eat and we use everything, then this is the time that we have to tell the family this is it, and we have to think about this is the progression of Alzheimer's, and that's the time to discuss, hospice care for the patients rather than discussing the tube feeding. Healthcare providers should be encouraged to discuss the future potential feeding problems and functional losses that accompany dementia with caregiver as a way of providing education about the disease processes. So that's a thing that we always need to talk about with the patient about the pulse and the family when we have a diagnosis of dementia. We need to make everything clear at that time rather than waiting to the last minute talking about the tube feeding, that a lot of patients ended up with hospitalization and tube feeding and going to the nursing home with suffering for longer time or period without any quality of life. Next, please. Okay, that was actually the presentation for now. And I think Dr. Segal is gonna follow the.
Thank you so much, Dr. Khaligi. Does anyone have any questions regarding weight loss in older adult patients or those who have cognitive impairment? You can either put your questions in the chat or feel free to unmute yourself and ask away.
Hi, everyone. This is Beatrice from UCI. I want to ask about the cannabis use. I know this is probably brought up quite a bit, and I know there's still a lot of controversy surrounding the use of cannabis to increase appetite. What is, are there any clinical guidelines, or what is, any professional organizations? What is their stance on the use of cannabis for appetite, especially in dementia?
Thank you so much, Beatrice. What a wonderful question. Does anyone have any thoughts about that?
I personally, I never used cannabis for that, but maybe we can ask Dr. Geriatric.
I know Dr. Geriatric well, and I can see she's got an answer for us.
Unfortunately, and I've looked at this pretty extensively, there's not a lot of research on cannabis use and the older adult in general. When you look at any indication, it's used a lot for pain management. If you look at those studies, there aren't a lot of older adults in those studies either. So there's very little information on how older patients respond to cannabis. The cannabis industry, at least in California, is very strong, and there's a great push for people to use it. And I think at this point, it's kind of a dangerous thing because there's just not enough information. Everybody seems to be okay with CBD oil topically, but I can tell you from personal experience, my mother used to use it, and she would, towards the end of her life, she would get routinely confused after the application of CBD oil topically. We occasionally have patients in clinic where physicians want to try Marinol, and it's unfortunately not covered unless there's a diagnosis of HIV or cancer. And if the provider thinks something like this could be appropriate, you could send them to a dispensary to get it. But those are very individual decisions that are made. I think for the most part, we generally don't recommend cannabis for weight to use in older patients, just because we don't you have to use just the right proportion of THC to CBD. THC can cause psychotic reactions and it's more psychoactive. So, in a demented patient, especially, it's really hard to predict what's going to happen and how it's going to affect cognitive status.
Thank you so much, Dr. Gurvich. Does anyone have any other questions or a follow-up question? I actually have a few questions. Actually, we have one in the chat from Natalia Mendoza. Can you comment on when you start dietary supplementation?
Oh, okay, that's a good question. So we can do actually, I had another slides, but I think we reviewed with Dr. Segal, it was making my presentation too long. So we can do mini nutritional assessment for the patient, and based off that, if the patient has moderate to severe malnutrition, then we can start the patient on supplementation. So it's a mini nutritional tool that is online. You can go get it, and then you can just assess the patient based off the data, based off the numbers that the patient gets, and if the patient meets the criteria for moderate to severe malnutrition, then we can start the patient on that supplements.
Thank you, Dr. Khaligi. Any other questions? I actually have a question regarding appetite stimulants. And my question is for Dr. Gurvich. Sometimes I see patients who are losing weight. There's a recommendation that comes from a specialist, consultant recommending an appetite stimulant. And I know Dr. Khaligi very nicely reviewed the appetite stimulants and their issues. But Dr. Gurvich, I was just wondering if you could sort of review for us the main side effects of the stimulants and why we shouldn't be using those.
So the first one that was on Dr. Khaligi's slide was periactin, I think. That's basically an anticholinergic. It's an old first generation antihistamine, and it's got a pretty significant anticholinergic profile, so it can cause confusion. And especially in your cognitively impaired, those are the drugs to avoid. The Megase that was on the list is actually a progesterone derivative. So there's an increased risk of DVTs and things like that. And like Dr. Khaligi said, if you do gain weight, it's mostly fat, which is not the good kind of weight. And that drug is also on the Beers criteria because of increased risk of thrombosis. The Marinol, I mean, that's a THC, kind of a synthetic THC product, and it can be appropriate in cancer patients and HIV patients who are losing a lot of weight. But again, in your cognitively impaired patient, I don't know that that's a great idea because of the cognition impact of the drug. What else were there? Paxil wasn't actually on this. Paxil is paroxetine. It's an SSRI. Of all the SSRIs, that tends to have a little bit more of a weight gain kind of a profile, but it is a little bit anticholinergic as well. So we generally don't use it in patients with cognitive impairment. Were there any others? I don't think I missed any.
Remeron, mirtazapine.
Oh, mirtazapine, sorry. Yeah, mirtazapine is the one we kind of use very liberally in our clinic. I think it causes weight gain in about 20% of patients, which is pretty significant. So most older adults will gain weight on mirtazapine. The biggest side effects that can cause is sedation. So if they have issues with insomnia and weight gain, you might give them a low dose at night. Sedative properties of mirtazapine tend to be at the lower spectrum of the dosing range. So as you go up, the drug tends to be less sedating, which is a little counterintuitive, and you can still get some pretty decent weight gain from that. The biggest side effects from mirtazapine would be dizziness, again, sedation. Sometimes it can cause hyponatremia, but it's actually less likely than with some of the other antidepressants. So we use it fairly often. So that's kind of our go-to drug that appears to be fairly safe and helpful for other reasons. It's an antidepressant after all. Anything else? Did I forget anything else?
No, thank you so much, Dr. Gervish. It was a wonderful review. Thank you.